All right. It's a new format like we were talking about, but hopefully this is interesting. The idea with this is we actually wanted to show controversial, kind of thought-provoking cases. So hopefully Darren and everybody over there won't beat us up too much on this case, because I already know what's going to happen. It's a CFA case. Everybody's going to get excited. But don't shoot the messenger. Can you guys load the talk? I don't see it over here. Oh, there we go. And how do I advance? There we go. My disclosures. So this is the story. 81-year-old gentleman referred by an outside vascular surgeon for right leg lifestyle limiting claudication, barely a half a block. And I'll show you why he was referred when I get to the images. His ABI was 0.5. He was put on a supervised exercise program for 3 months, no improvement. He's a very active 81-year-old, so he hikes, he does tours throughout Europe, he goes to Utah, he goes everywhere, he skis. So this was really affecting his lifestyle. These are his risk factors: heavy smoker times 50 years. He had since stopped a year before. Hypertensive, hyperlipidemia, the usual risk factors. Past medical and surgical history, you could see he's had previous MI, triple bypass, AFib, couple of ablations. He was previously treated with a right common iliac artery stent a few years ago for claudication, but now he returns. And there's his medications of note: Pradaxa, 81 milligram aspirin. Labs were within normal limits. So he's referred by the vascular surgeon because the vascular surgeon said, based on this imaging, which I'll show you now, densely calcified abdominal aorta, iliac vessels. I think you can kind of see the stent in the right common iliac artery. He has one on the left side too, by the way, but you can barely see it because of the dense calcium. And you can see there's calcification in that right external, the right common femoral, extending into that proximal SFA and a little bit of the profunda. So the discussion when he called was, I don't feel comfortable operating on this guy. I think he needs something done, but I don't think I'll be able to get proximal control safely. That was what he told. That's what he told us. So patient was sent to me. I then saw the patient. I then called our chief of vascular surgery. I said, hey, can you take a look at this guy? Because I think he probably needs an endarterectomy with a patch, maybe some, a hybrid treatment, fix that external, and take care of everything else at the same time. Our vascular surgeons looked at it and said, yeah, we don't want to operate on this guy for the same reasons. I said, well, how about I put a balloon up to get proximal control? You do an endarterectomy. No, we don't think we want to do that, which was fair, right? They assessed him, sent him to one of the other vascular surgeons in our group. Same discussion. This is what it looks like to show you what the common femoral looks like, barely a lumen. Look at the SFA, again, very thin lumen. You can see that CFA middle image on the bottom. Again, dense calcification. And look, I used to go in with our chief of vascular surgery to see all the endarterectomies. Common femoral artery looks terrible. And all the stuff they pull out of there, whether it's clot, whether it's, all this endo, I'm amazed endo ever works in the CFA, to be honest with you. I still think the gold standard is endarterectomy. But now we have this patient. You know the story. Some additional images. There is a significant external iliac artery narrowing, common femoral, proximal SFA. Showing it to you there. There's ultrasound. You can see it's pretty densely calcified. Some duplex waveforms to show you the Doppler. So we have, inflow disease. We've got common femoral disease. Profunda is open, but it's not the, again, there's dense calcification and plaque extending into there from the CFA. So the first question to our expert esteemed panel is, should this guy even be treated? Lifestyle limiting claudication, can barely walk a block. He wants to go to Europe again and hike the mountains with his wife. He's a pretty active guy, despite some of the comorbidities that he has. previous MI, but he's been treated by bypass, AFib with ablation. So now you guys can vote. Well, for the panelists, go ahead. Why don't we just start at the beginning here, Bill, if you don't mind starting. I think your mic's off. Is the mic off, guys?
Do I have a mic? There you go.
There we go.
So I think if the question is, does he have an indication for treatment, the answer is yes.
Okay.
It doesn't look like he's going to get better on medical therapy. He's limited. He wants to do more. You could try him on some Celestazol, but I don't think it's going to change his.
Okay, he failed Celestazol, by the way.
Yeah, there you go.
He didn't tolerate it. Okay, Kumar, Darren.
So
Dan?
I think someone's trying to set you up for this case, but you have a patient who apparently has been very following the recipe. He's tried everything, and you have two surgical opinions saying not possible. I do agree it's going to be a very difficult one to treat, especially when you have that eccentric, chunky calcium like that. But I think if the patient's willing to undergo, knowing that the long term you don't know yet, and sometimes there's some complication issues, I wouldn't be opposed to treating it.
So actually, let me clarify. I think he should be treated. I didn't say how he should be treated. I
Right.
actually think you should.
Well, this is the first question, so
I think
the
you should send him
second
to
question will
Philadelphia and let Darren do it.
be how.
Darren can do this with an open procedure. I'm sure of it.
So I think for Darren and Dan and everybody else on the panel, just tell me, would you treat this gentleman, given this, forget about how, because we're going to get into that,
Yeah.
but rather, do you think this guy is there an indication to treat him, whether it's surgery or otherwise?
Well, I think that you have to have a real discussion with the patient and have to have some patient-centered decision-making. I mean, because he has to understand that, first of all, it's not life or limb-threatening what he has.
Right.
And so he has to be debilitated, disabled enough that he really wants to undergo a procedure that I would also tell him probably is more difficult than the typical procedure that we treat, and that may have some slightly increased risks compared to a patient who didn't have that extent of calcification and complexity. And if he wanted to be treated, having understood all that, then I would treat him.
Okay.
And I would say the same thing. He's undergone exercise therapy. He's failed that. And he's, for his regular life, he's incapacitated. I don't see a question as to why you wouldn't offer this patient therapy.
Some treatment. John, same thing?
Well, the only thing I'd add is I would say to treat him, but I don't feel like this has been anatomically defined fully yet, as to what's involved. I mean, there's so much calcium. I wonder if this is a rare case where you do like a diagnostic angio, so you sort of see what you have, can you come up and over? Is there?
He's got a gradient across that external common femoral and proximal SFA.
Right. I mean, I would say, should you be treated? If possible, yes. But
Okay.
anatomically, it's just impossible, and your opinion.
And did everybody get a chance to vote in the audience? Yes? You guys show that? All right, so 90% say yes, 9% say no. Okay, reasonable. So let's go on to question number 2. How would you treat this patient? We got 3 vascular surgeons that said no. But we have our esteemed experts. We got Darren, we got Dan Clare. What do you guys think? How would you treat this if you saw this patient, Darren?
So I need a little bit more information. I'm with John.
Okay.
I don't know how bad the external iliac is, too. I know there's calcium.
Yeah.
But does he have severe occlusive disease that warrants treatment?
There's a monophasic waveform in the external.
In the external. So the external needs to be treated as well. He's got
Yes.
a common iliac stent.
And common femoral is monophasic, and so is
But
proximal.
this is not just a common femoral lesion. This
Correct.
is an external and a common femoral.
Yes, that's correct.
I share all of your vascular surgeons' concerns that this is a non-clampable artery, potentially.
That's what they're worried about, is rupture with clamping. I mean, I'm not a surgeon, so I'd have to defer to you guys.
No, I think it's a real risk, and certainly if you're up, through a groin incision and trying to push a clamp up into the retroperitoneum and that ruptures without control, that can be a dangerous situation. So I think you have to plan to be able to deal with whatever you encounter. And this is actually something that I would consider potentially a hybrid treatment. I do think that the best treatment for the common femoral segment and the common femoral bifurcation with a lesion like that is going to be endarterectomy. Sounds like he's a reasonable candidate for endarterectomy, except for the calcium. but proximally, I think you have to be creative. And so I'd be considering something, a hybrid approach with a covered stent, pave and then crack, use a balloon for proximal control, do the distal end with end arterectomy and a patch. And I think that that would be an effective treatment. And by relining the external first with a covered stent, you can protect against the rupture bleeding issue to some extent.
Okay. Dan?
So, I'm just going under the assumption that the common femoral and the external iliac on that side are the problem. And
Yes. Yes.
frankly, I don't think this is that atypical situation. I mean, it's something I see and deal with all the time. And we use balloon occlusion. But one of the advantages to using balloon occlusion is you can make your incision low on the common femoral artery. You can balloon occlude 8 to 10 centimeters up, and you can actually pull out plaque 3 to 5 centimeters above where your arteriotomy is. So you put the balloon up, you open up the artery to here, and you clean out the artery intervening that segment, and then you take the balloon out and you just put a clamp on an end arterectomized artery, which we do all the time. We do it in the aorta, do it in the iliac arteries. I have to admit, I don't see this as like incredibly complex.
Complicated. Okay.
With that said, I think you have to have some method to treat calcium here. Darren said, pave and crack. I would use shockwave in this instance, and I would have it available to treat it. And I've treated patients because of some other anatomic restriction on operating on them. Either they've had a previous infection in their groin or something else and have heavy calcium, and I could see using shockwave here in the common femoral artery and at its bifurcation as well.
Yep. Anybody else, John?
Yeah, I like your pave and crack idea, but tell you the truth is, this is sort of routine. You come up and over from the left side to find the anatomy, go ahead, do IVL. At that point, angioplasty, and we use a lot of Supera stents. The VMI data from Kundalus is very favorable, and with regard to some of the other comments, should this patient need subsequent surgery, at least from what I understand, they pull out pretty easily if you need to do surgery down the line. That may not be entirely true, but certainly Kuhn tells us that's not a limitation. So I think this would be an endovascular case with IVL and probably Supera stent across that common femoral.
Okay.
Can I?
Yeah,
say
yeah, of
something?
course.
I really just want to say I've seen Kuhn's data, but the one thing that he doesn't really account for is the loss of the profunda with these Supera stents across the thing. And I think he's probably right. It probably works very well for the common femoral, but I do think you sacrifice the profunda a lot of times. And yeah, you can remove it, but I don't like to be doing something where if I go back because there's a problem, it could be a catastrophic problem because you can lose the SFA and the profunda.
Yeah, so if I may, I've given a number of talks about CFA, and in doing that, I had a chance to look at the various CFA classification, disease classification. And, for the most part, with the classification you use, if you extend that stent across the profunda and the SFA, there's no differences in outcomes out to 3 to 5 years. And probably it's because they're filling via collaterals anyway, the profunda. You never really had straight line profunda flow to begin with, so you're not compromising anything if the profunda goes down outside the stent.
And I think to be clear, the gold standard is end arterectomy with patch. That's the bottom line. This is not meant to say, let's all treat CFA disease. It's just that this is a unique situation. What do we do? And so we want to make sure that we have a discussion about it. But gold standard is definitely end arterectomy with a vein patch. I would think you guys would all agree. Can we show the results of this? B, so calcification is a problem, hybrid approach with proximal balloon occlusion for control and CFA endarterectomy. I like it. Let's go to the next question. For those that would fix it endo, it sounds like we had one answer. For the people on the panel, would anybody do this endo? If the guy said, absolutely not, I don't want any surgery at all.
So I'll say, I think the salient points here were a couple. That what is the anatomy, where's the profunda involvement? It's a little hard to tell purely on that CT, but I think you see enough. If you treat this endo, which let's say Darren and Dan are at some other country right now, and we don't have access to it. One thing I was interested, I was at a course 2 weeks ago running it, and we had a similar conversation, and 3 of us found out that in some of these situations with eccentric, we've done the same thing, which is a lot. It's going to be unpopular, but shock, hock, and DCB, because what happens is, you're not going to be able to remove that, debulk it with the shocking, which I think is the value, but
Right.
if you can debulk it after shocking it, it gets soft. And I know we don't have data on this, but a few of us, including was a surgeon, cardiologist, and me, and we said this is something we've tried in a few of these eccentric if the profunda is not going to be compromised. So that's it's maybe overkill, but it helps soften it.
Okay.
I actually don't think shockwaves can be effective here. I think the calcium's way too thick. At least a couple of the slices we saw on the CT scan, I don't think you're going to get a great result there.
Yep.
And so I don't love any of these choices, honestly, but I chose one. Because, yeah. Yeah.
All right. What about everybody had a chance to vote in the crowd? Okay.
I actually
Yeah,
do
yeah.
think you can get, you're not going to get an ideal result with shockwave. You will likely need to come back. But I do think you could probably get the individual improvement with that, with the DCB. And yeah, you may need to come back, but I'm not convinced that,
Do you think this is going to need a scaffold, Dan?
ideally, I don't want to put one there. So, I mean,
Right.
I'm not using that unless for some
Agreed.
reason or another, what I'm doing hasn't been effective.
Got it.
I mean, I think, you know, we have to,
And we've got
when David was chiseled, it was out of the best marble in all of Italy. Okay? And so you got the David. This is not the best marble in New
agreed,
York City.
100%.
So you're not going to get the David. So I think we have to be, you know, we have to be realistic about what
Right.
result we're going to get here. And I'm okay putting a superior, I'm okay putting a stent across this thing because while I agree I don't like to do that, I don't love to do that, I think I have to go in with that as one of my options on the list in a sequential kind of rank order way.
Yeah, I guess I'm saying
No, I know, yeah.
I'm not
I
saying
just want the
don't, I'm
audience
just-
to know that
yeah.
I don't think that's a absolute.
It's not horrible.
Yeah.
Yep, I agree.
Yeah.
Just so interesting, 'cause these are, you know, I admire these guys' opinions so much. We've known them for a lot of years, and you know, just our approach is different, even amongst us. And you know, we've been very liberal putting Superiors across the common femoral artery for many years now. The patients do great; they come back, they're doing well. So when I hear Dan say he wouldn't want to do it, I'm like, wow, you know, it's like shocking to me because obviously.
Well-
The smartest guy I know, but he's not doing it. I am doing it. I don't know if I have to kind of.
And Super Surge, you know, RCT is going to come out, it ends 2024. Maybe we'll get some data by 2025, right? 1-to-1 randomized superior stent versus endarterectomy. Primary endpoint, primary patency, right, at 3 years.
So I'll just say that first
We'll
as a
see.
disclosure, I have done endovascular treatment of the common femoral artery as a vascular surgeon, and I do think that there's a role for it. But I also think it's limited, and it's limited to patients who don't have surgical options, whether it's due to comorbidities or
What about
other
choice,
anatomic issues.
Darren? If they
I
said,
don't think it's necessarily choice.
they said they
because
didn't want
my
to.
job as a physician is to tell my patient what I do believe is the right thing, and I don't let patients necessarily dictate how I'm going to treat them. I'm going to offer them what I believe to be the best treatment, and if they decide to go see somebody else because they don't agree with it, I'm okay with that.
Fair enough.
But I don't compromise my position on what I think is the best treatment for the patient. I just try to have a discussion with them and make sure that they understand it. Common femoral artery endarterectomy is not an evil procedure. It's been done for a long time. It
Yep.
has outstanding results. I have used Supera in the common femoral artery. I've had good results with it, but I've also had some results that are not great. One of the limitations also is on the size matrix that's available as well, depending on the vessel size. I have pulled some out of patients when profunda has been occluded by it, so it does happen. And they don't pull out that easy. You have to do the endarterectomy to be able to remove the stent, and sometimes the wall can get so thin that then you have to replace or reconstruct the vessel. So I do want to dissuade people that the concept that it's totally benign and we can just pull the thing out if we end up having to do surgery is flawed logic.
Did you have something you want to say, PK?
To the panel. I mean, in this claudican, why not do endovascular or both, but in the sense, accept an inferior result in the common femoral and stent the iliac properly to increase the gradient or decrease the gradient across and improve his claudication, I mean, without stenting. So what I'm saying is rather than, because I'm kind of against stenting the common femoral as well, so do a shockwave balloon or a serenator or whatever it is to get a luminal gain, stent the external iliac, and then obviously increase the flow down, reduce the gradient, and you'll likely make this guy feel better. Any thoughts on that? Would anyone do that in the sense? And just rather than go after a perfect result in the common femoral, accept a result that's inferior and then see and maybe bring him back at a later date.
I think that's kind of what I was saying, that, I would treat the iliac aggressively here. I would use shockwave in the common femoral, accepting what I get, understanding that I might have to come back and re-intervene in the common femoral, if that down the road was a problem or didn't relieve his symptoms.
Okay. Can we show the results of this? So shockwave DCB is the thought so far. And obviously we're going to fix the external too, probably with a covered stent, shockwave, etc. Okay. Can we go forward one? All right, so here's the angiogram up and over. This was discussed at our conference with our surgeons. Patient wanted treatment. We still thought, we thought fixing the external with a stent, etc., made sense, and that he should undergo endarterectomy with a patch and so forth. He said no. We talked to him over and over. He said, I want something that's affecting my life. So we said, okay. So here's our angiogram up and over. We definitely had a gradient. You can see that external, there's the kind of right up to the inguinal ligament. You can see it's pretty densely calcified like it looked on the CT. Nice coral reef calcification in the common extending into the profunda and the proximal SFA like on the CTA. Definitely had a significant gradient. Shockwave balloon. Did all the cycles we could in the external, the common, and the proximal SFA. We have a wire in the profunda to protect it because, like everybody said, we want to protect that profunda as much as possible. This is what it looked like on IVUS after shockwave and POBA and DCB.
Oh, after DCB too.
Yep.
Still pretty
Now
painful.
what?
Are you sure?
Yeah. Unfortunately.
Just Googling it.
Did you turn on the shockwave? I actually am not surprised. I mean, kind of.
Yeah, which makes sense, right, based on what we saw in the CTA. So the question is now, this is what we have. The external we know we can fix, right? We can put in a covered stent. We have some tools we can do that have pretty, good data. But now this is the common femoral. This is what it looks like.
So Srini, this is before the iliac treatment?
This is before
the common foam SFA.
Yeah, the external has not been treated yet. That's correct.
So the angiogram looked more coral reefish to me.
Yep.
And that, I don't think that ever really responds well to shockwave. So,
I can go back one. Are you
yeah,
able to
go
go
back.
back one? Can you go
you could think about directional atherectomy in that. You'd have to put a filter down.
Yeah.
I'm not opposed to using a jet stream or something like that here as well. I think that'll cut orbital atherectomy. Something to score that, kind of start the process that a balloon might be.
Can we go back to the CT images, though, to show the cross? If you go, just a few more. I'll keep going to before question one, just so we can look at it. One more, right here. So I don't think wouldn't directional be tough here?
No, I mean, that's what I was talking about earlier. What we just said,
Shockwave it
when
and then
you
do
shocked it,
directional.
and if you've done the in vivo testing with it, you'll see how it softens up. And I think if you had to, and you don't want to put a scaffold, it's on the medial side more. I think you can direct it that way to get a better luminal gain at least.
Okay. Any other comments?
Can I add something sort of technical here? First
Yeah.
of all, I get the sense I'm more endovascularly aggressive than
Okay.
a lot of people here, so I'm going to discourage anyone from doing what I do. But I think that's something that's really relevant here. And we actually make a point of this, is when you recanalize that common femoral, we try to stay on the profunda side. If your wire is steering away, if the profunda is open to begin with, if the wire is steering away from it, there have been a good number of cases where I'll do a micropuncture into the SFA, go retrograde, make sure I get the wire on the profunda side, so when I balloon dilate, I'm dilating on that profunda side rather than putting plaque up against it. So just sort of a little bit of a technical note. And doing those sort of things, as you've already heard, I'm doing this with intent to stent because this is what it looks like with IVUS afterwards. But again, I discourage you from doing what I do.
So would people fix the external at this point and stop? Leave this like this? Is that really going to make them any better?
Did you have a pre-IVUS?
Let's look like this.
Any better? I mean, it doesn't look much
It
better,
doesn't look much better. No.
despite your efforts.
All right.
He's discharged after his endarterectomy already.
Right. Well, that's what he needs. Is
Let's
an
hope.
endarterectomy.
Let's hope so.
So here's our choices now.
I don't like those choices either. Well, you could talk to the vascular surgeon. I like that choice. but
I got a problem with the Supera in this
Yeah, me
setting
too. It's
because
not
you're
done.
It's,
Not gonna
you're,
expand.
It's not ready.
That's a problem with where it is.
Right.
Yeah.
And I'm not just talking about in the common femoral artery. I'm talking about you got, a 2 millimeter, 3 millimeter lumen.
Yeah, it's not ready for a superior.
You're ready for Supera. Okay. Did everybody have a chance to vote? Okay. What do we got?
Oh,
So 30% stop. Oh, it's changing. It looks like everybody that said B, raise your hand. No, I'm kidding. Okay, so it looks like B wins a little bit, right? Leave it alone, treat the external. But that's not going to fix this patient. They're still going to be pretty symptomatic. But
You
we
also don't
talked
wanna
a
make
few
them
more
worse.
into talking to Darren and Dan.
Ultimately, he'll come back to
it
us.
might become.
Yeah,
a
he's coming
can't.
back. All right. Here's what this guy ultimately had then. He ended up getting a Supera. And that's the pre and post IVUS.
Surprisingly opened.
And fixed the external with a covered stent, basically.
I'm
Can't
sure
go
it's the same
forward.
patient, right?
So now the question becomes, what do we do post-treatment? The guy's already on Pradaxa and aspirin. Do we just leave him on that and just see how he does? I mean, is there any reason to change it at this point? History of AFib, et cetera? Nope. Everybody vote? Okay, what do we got? See if it changes. DAPT, we heard today, no data, right? Brilinta, aspirin alone. You're better off with aspirin alone if you're going to do DAPT, as they said. So the majority say, yep, keep them on Pradaxa and aspirin. Okay. Anybody different on the panel?
I mean, he's got a lot of risk factors already, right? He's got the MI, he's got the AFib,
Yep.
all that stuff. So I mean, I'll vote. I said A.
So this is a 2.5-year follow-up. There's his non-invasive test with his ABI. Remember, his pre-ABI was 0.5. He's at 1. Oh, can you guys show the slide? Sorry about that. That's his follow-up.
Pretty good.
Obviously, his symptoms resolved, which we assume. This is his duplex ultrasound of his Supera stent. The top there is the pre-intervention, post is on the bottom. So triphasic waveform for the most part, I would say, and that remains stable at 2.5 years. And then his profunda, because we're always worried that, you're jailing the profunda, you're basically covering it. So, and it's still open, thankfully. I think this is what a lot of people are talking about. So now with this, and with data from these studies, we're still waiting for SuperSurge RCT. Is it ready for prime time? Can we show the voting? If you vote A, you're dismissed.
With regard to that answer, let's ask the surgeons. And Darren, you already alluded to this. If you treat this endovascularly and it fails, how much is a compromised subsequent surgery?
I mean, it's definitely doable. You have to do an endarterectomy, and sometimes I think you have an increased risk that it's going to be more extensive and that you may actually have to replace the vessel if you're not left with much after the endarterectomy, which sometimes is the case with transmural calcification. So I do think it potentially makes it a little bit harder. So I wouldn't say that it's a total, gimme.
Yeah, I'd say the same thing. It's a more difficult operation because there is more inflammation around the vessel than there is with just native atherosclerosis. And the other thing you can occasionally run into that's a bit of an issue is, especially in this situation like this, if you've treated the external iliac with a stent and then you've stented the common femoral, one is inside the other, that can make it a little bit challenging. But honestly, it's still just an endarterectomy and can be done.
Yeah. Bottom line, we still believe that endarterectomy is the gold standard. This is not the normal case, even though we're showing this we're not showing this to mean that this is what should be the primary treatment modality.
I have to say that had I treated it endovascular, I would have done it the same way, and that I do think that this is
That's fair.
a lesion that lends itself best to scaffolding with Supera just because of the nature of the calcific disease. But in a surgical candidate, I wouldn't overstent the profunda.
Yep.
You know, if I could limit it to the common femoral, I'd be more apt to do something endovascular, but involving that femoral bifurcation, we can reconstruct it so nicely and make it back the way it was many, many years ago. That would be my preference.
Yep, great discussion. Thank you.
Thank you.
wanna
Thank you,
show
Srini. That's
the
a great,
next one?
great job. Thank you.